Hello and welcome to another YouTube tutorial. My name is James Piper. I'm a Senior Fellow and a Clinical Lecturer in the specialty of Acute Medicine for UCL undergraduates. Welcome. In this talk, I aim to cover the three aspects of the Acute Medicine curriculum for undergraduates, and that includes to discuss planning and interpreting relevant investigations, blood tests, ABGs, ECGs, X-rays, to recognise some common acute medical problems and emergencies and their management, and to importantly to understand how acute medicine works. Now, acute medicine is a relatively new specialty. It's only just about a decade or so in forming as a new specialty, so we are relatively new and often quite nebulous. Obviously, acute medicine is relatively difficult to understand compared to something a bit more simple such as gastroenterology or cardiology. Important skills of the acute physician include good communication, teamwork, and skills in handover. So today I'm going to talk about acute medicine and what it means, clinical concepts in acute medicine, talk a little bit about assessing the unwell medical patient, some of the practical skills that acute physicians have, some of the professional aspects. The acute medical skill of clerking is covered in a separate tutorial. So acute medicine is basically the specialty that deals with medical emergencies, and where our referrals come from is twofold. Patients can be referred via their GP directly to the acute medical team, and often this is done via email or a telephone conversation with a relatively senior doctor who can decide whether the patient needs to come into hospital or whether the patient can have a delayed referral and review or be seen as an outpatient in a separate service. We also, of course, take referrals from the emergency department, and this is where most of our admissions will be from the ED. GPs, of course, will sometimes send patients directly to the emergency department, who in turn will then refer to the acute medical team. The acute medical team on duty usually comprises of a consultant on call, a lead registrar, several core training doctors such as IMT or CTs, also from the training program ACCS, medical students, and also FY1s and FY2s. So it's important to understand the demand for acute medicine by understanding the pattern of A&E attendances. And so this is data from the government, from NHS England. This basically looks at emergency department attendances from 2004 to 2016-17. And there are three things to look at here. So first of all, there's total attendances, and you can see that basically that has risen from about 18 million to probably by now about 25 million attendances per year. Now you'll notice that patients who were seen within 4 hours has plateaued since about 2010, and those patients who were seen over 4 hours have steadily started to rise again. And I think this reflects twofold. There's an increase in patients using emergency departments inappropriately, such as an alternative to their GP, or attending the emergency room for minor injuries. But I think probably more importantly is that the complexity of patients that are now coming into hospital, such as the aging population, more frail population, those from nursing homes, and with complex care needs. Also, people are surviving much longer with different diseases, including congenital diseases, genetic diseases, and so on. So the complexity of the patients that we deal with in acute medicine is rising fairly quickly. Now, when we look specifically at age, you'll see here that the headline figure is that people aged 18 and above have the highest rates of A&E attendance. But in terms of raw numbers, ages 20 to 24 are the most common adult attendees. But you'll see here that per 1,000 population, 90 nonagenarians have 860 A&E attendances per 1,000. So that's a very significant influx of patients that we have, and so these patients are often rarely able to be discharged straight away from the emergency department. They'll need specialist input such as from the geriatricians or the acute frailty team, and very rarely can these patients be turned around within 4 hours. For example, if an elderly patient comes in late at night, it is very unlikely that we'll be able to discharge them safely overnight, whereas if you have, say, a 25-year-old who can be discharged at 2 o'clock in the morning, it is more likely they'll be able to go home to a safe environment. Also, particularly complicating or geriatric discharge is often care packages that might get cancelled when a patient is brought to the emergency department. We then have to wait for it to be restarted again, further delaying discharge. So it's important to appreciate the spectrum of ages that present to the emergency department and their relative complexity. Now, obviously, children obviously present to the emergency department again fairly frequently, but again, this tends to be for relatively minor illnesses, so they have a quick turnover. Very few of them are pediatric emergencies. So this again is the data that I was just showing you is again buttressed by data from the King's Fund, which basically gives you a projection of the index value of total attendances and admissions via major emergency departments. Now you'll notice that when you look at the total attendances again, you can see this is slowly rising again, as shown in the couple of slides ago, but you'll notice how much more the number of admissions have arisen. So what that's basically telling us is, although the relative attendances to major emergency departments is rising, albeit slowly, of a proportion of which of those that are being admitted is significantly higher. Now this of course puts down pressure on emergency departments, acute medicine departments and specialist wards, because if we have a much higher proportion of patients who are being admitted when they come to the ED, we'll obviously need to find beds for them or arrange alternative specialty pathways such as outpatient hot clinics and so on. So the rise in those being admitted has obviously driven the progress of acute medicine as a specialty and developing same-day emergency care models. So how does acute medicine fit into the hospital? So as I was saying, you have the acute medicine unit, which obviously takes patients from the emergency department and also directly from the GP. A lot of hospitals, including this one, have a same-day emergency care service or an ambulatory emergency care. The two effectively mean the same thing. So GPs may directly refer to the AEC, and this will be things like for minor medical problems such as cellulitis, query DVT, PE, and minor medical problems. So patients can come in, have antibiotics, or have their Doppler assessment for VTE, and then can be discharged the same day and followed up as a walk-in. If, of course, a patient is more unwell when they arrive in the AEC, then, of course, they can be referred into the inpatient acute medicine bed base. So there's a sort of constant cycle of those between the AEC GP, the acute medicine unit. Patients, of course, are largely referred by the GPs or directly referred via their nursing homes. Of course, patients can self-attend to the emergency department, and then those cycles are shown on the diagram. Now, of course, if a patient attends to the acute medical unit, ideally patients should really only stay on the acute medicine unit for about 24 to 72 hours. Certainly if their stay is anticipated to be longer than that and or they need specialist treatment, such as by the cardiologists, then obviously they should be admitted to a specialty ward. And again, this is where delays can come in the transfer of care. Now, if we look more closely at the different interrelationships, this is what I've described as the acute planets of the acute medicine universe. You have the emergency department again. That's the center that is at the center, which is parallel to its sister in the acute medical unit. Now, this in turn has a complex web of relationships. So, for example, in the emergency department, a patient who may be seen by the medical team may actually need critical care, and that's been fairly our common experience with patients who have deteriorated due to COVID and have needed respiratory support. It might be that a patient presents to the emergency department who has an acute stroke, and they may be transferred directly via the medical team to the acute stroke service, or in fact they may not involve the acute medicine team at all. If the patient presents to the emergency room and they have a relatively minor medical problem or have come for a primary care issue, such as they've run out of medications, then they can be directly referred back to a GP urgent care or walk-in centre. Patients, of course, will present with mental health crises, and these patients can be referred from either the emergency department or the acute medicine unit. Some hospitals are a level 1 major trauma centre, such as the Royal London, and we have close relationships, of course, with the ambulance service and therapy teams. The therapy teams have direct in-reach to the emergency department, acute ambulatory care centres, acute assessment units, surgical units and critical care. The acute medicine unit has specialty inreach into our own ambulatory care services. We have patients who will need a primary PCI, such as for a ST elevation myocardial infarction, and they will be referred directly from ED or the acute medical unit. Obviously, from the AMU, patients will often be sent home, or they may be sent home but with MDT CNS services, so clinical nurse specialist services such as the diabetes team, or it might be malignancy services. If a patient, for example, has a GI bleed, they might need follow-up and specialty care on the gastroenterology ward. Occasionally, medical patients actually get referred for what is thought to be a medical problem and actually have a surgical problem. So again, there is liaison between the medics and the surgeons. Obviously, underpinning all of this relationships, of course, is access to radiology, making sure that our patients can get their CT scans or MRI scans in a timely fashion. Also, our diagnostic support, so ultrasound, laboratory testing, and other diagnostics that we will need in order to proceed with the patient's care. When we further have a look at our acute medical universe, outside the hospital, we've already talked about the relationship between the emergency room intensive care unit and the acute medicine unit, but of course there is an even wider relationship, and of course the majority of our patients go home, but of course it may be they get readmitted to the emergency department. Some patients may come in from their own home, but of course be moribund or disabled in some way by the illness of which they have come, and they'll be discharged to a healthcare facility or a nursing home instead. Now, of course, some hospitals aren't able to provide all level of services. So a district general hospital, for example, might not have a cardiothoracic unit, whereas a university teaching hospital will. So, for example, here at the Royal Free, we don't have neurosurgery or cardiothoracics, but we do have a liver unit, of which so we are a national transplant centre. But if a patient needs cardiothoracic surgery, then they get transferred to the Royal Brompton, or if they need neurosurgery, they'll go to Queen Square Centre for Neurology and Neurosurgery. One of the most important skill attributes that I would recommend that you all try and develop by the end of your acute medicine time is to be able to look at a patient and understand what a sick patient looks like. So, for example, this patient you might not think doesn't look sick, but you might think of him as frail or vulnerable. So for example, he doesn't have any oxygen on. He's got what looks like a cannula in, but there's no drips running through. He's alert, although he's quite drowsy. You'll also notice, however, if you pay attention to his skin, he's obviously had multiple falls. He's got plasters on. He's got bruising. He's got very little. If you look at his wrists, you'll look that he's got significant muscle wasting of the wrist and hands. You'll also notice it has very significant wasting of the frontalis muscles. So what I'm trying to get at here is, although this might not be sick in the direct sense, these patients are frail and vulnerable and highly at risk deteriorating rapidly from an acute insult such as pneumonia or pulmonary embolism or a fall. So this patient probably doesn't look sick at all. So he's quite well, he's well perfused, he looks very well, he's not got any obvious rashes, he's got a thermometer in, so one presumes he has a bit of a fever, but relatively he looks quite comfortable. But actually, you'll often find that patients can sometimes disguise the severity of their illness by how young they are, and again, it's important to take that into account. So, for example, what I mean when this young man could be sick is actually some of the headache patients who tend to present in this age group actually have quite a serious pathology such as glioblastoma multiforme, space-occupying lesions, and other tumours. So, although conventionally you wouldn't count him as a sick patient because he's young, physiologically fit, healthy, with no obvious comorbidity, actually when he presents to the emergency department, say with headache and blurred vision, it could very well actually be something serious such as a space-occupying lesion. And so it's important to think about the different pathologies that you might see depending on age and sex. This is probably a more conventional view of a sick patient. Obviously, this is a simulation, but you can take my point. This is a patient who's obviously simulating being collapsed on the floor. There's an attending physician there. There's multiple nurses in the resus team. The patient is in a resus room. As you can see, there's obviously lots of equipment around. So this is probably what we see as a more conventional sick patient. You can see, if you look closely, the patient's got defibrillator pads on and has also got an endotracheal tube in situ. So this lady is having chemotherapy. So again, she might not be acutely sick. So for example, patients who get referred to acute medicine may be on their third or fourth or even fifth, sixth cycle of chemo. But actually what that does mean is that, again, they are at high risk of neutropenic sepsis, complications from their cancer such as mucositis, dehydration, radiation enteritis, so diarrhea, vomiting, and other sort of radiation or chemotherapy related complications which can then present to the acute medicine department. So again, these patients might not be acutely sick, but they are highly vulnerable of much more complex infectious diseases because they are immunosuppressed. The vast majority of patients obviously survive to discharge, but a important number of patients do not, and it's equally important that we pay just as much attention to those who are not going to survive their admission as much as those that are. Remember that families, for example, the last memories and things they will have of their relative, especially if they're in hospital, is how we cared for them and how well we cared for the patient in their last days and hours of life. So although this lady isn't having any intervention, she is just as sick, and it's important that we don't decategorize these patients, that we make them just a priority so that patients die with peace, dignity, and hopefully pain-free. This is probably our most conventional image of a sick patient. This is a patient who's being resuscitated. This is a photograph from the University Hospital of Michigan. And you can see, obviously, there's an entire resus team here. They're obviously doing CPR. The patient is intubated, being ventilated. Obviously, is having injections of drugs. So this is much more of a conventional sick patient, but it's important nonetheless to appreciate that there is a spectrum of illnesses and in acute medicine, that the variety is wide. Obviously, we've already talked about the top left. You can see these patients are having a cardiac arrest. This is a patient on the right hand side, as you can see, is having ischemic chest pain and obviously is probably having a myocardial infarction. On the other hand, however, we've got our patients who have frail, so who are more likely to have comorbidities, complicating, higher risk of hospital-acquired morbidity such as falls and hospital-acquired pneumonias. And so it's important that they get expert specialist attention early so that we can discharge them before, frankly, something may happen to them. So then, of course, we've got our palliative care. So we've got acute palliative care. And then, of course, with the COVID pandemic, obviously, we've had a public health emergency, which has radically reshaped how we deliver acute and emergency medicine and also critical care. So as well as being able to recognize acute illness, it's also important to be able to be familiar and read the charts. So recognizing trends in vital signs is a really important skill to have. You've got to be careful about not misinterpreting raw numbers, because remember that for most patients, they will be different. Some patients, of course, will have a normal high blood pressure. Others will have a normal low blood pressure. So, for example, those who have chronic kidney disease and are dialysis dependent often tend to have hypertension, whereas young teenagers who have eating disorders tend to have low blood pressure. So it's important that you read any observation chart or any news score in the context of their physiological baseline and what's their normal. It's also important to appreciate that patients who are normally physiologically quite young, fit and healthy, they will often deteriorate at a slower time frame, but they'll deteriorate much sharper, whereas older people will often deteriorate faster and at a steeper angle. So what I'm trying to say here is that frail people will obviously naturally deteriorate quite quickly because they have much lower physiological reserve, whereas younger patients who are fit and healthy with no comorbidities, they may seem stable for quite a while, and then they will suddenly become catastrophically unwell because they'll deteriorate, they'll get tired, their ability to compensate will have been tipped over. A good example of that is an asthmatic, for example. A patient presents with a moderate asthma attack and is left in the ED, and unfortunately they continue to get more and more short of breath, their asthma gets worse, and a couple of hours later they've collapsed in a heap with respiratory distress and need immediate intubation and ventilation. It's really important to appreciate nursing tuition. Now, there's a lot of evidence to suggest that actually nursing tuition is a very good predictor of those who are likely to have a cardiac arrest. Obviously, nursing intuition by itself can be quite difficult to be specific, but listen to your nurses. If they tell you that they are worried about someone, they're telling you for a reason, and usually their intuition is pretty spot on, so don't neglect to explore that with the nurses if they come to you. Now, it's important to remember the News 2 score that it is just a framework. Don't use it as a cosh or a framework or a cage in which to hold yourself in. The News 2 score really should already be supporting what you think clinically, because patients can have relatively low early warning scores but actually be catastrophically unwell, and vice versa. Patients can have a high early warning score but be quite stable. A good example of that is a patient who has COPD, who probably has AF, so they'll be tachycardic, they'll have chronically elevated respiratory rate, they'll have chronically borderline SATs. So they will never fit into that normal category. And again, it's important to appreciate that the early warning score was designed on a normal population, and nobody likes to be pigeonholed or sort of stereotyped, and so neither should we do that to our patients. It's important that you appreciate the individual factors that go into their physiology. If you have a quick look at the chart on the left hand side, you'll see that the first date is the 17th and the date after is the 20th, and so you can see how the window of opportunity that was lost here, obviously once the charting stops, that's because the patient's had a cardiac arrest. You can see how quickly the respiration rate steadily climbs, saturations drop, he becomes rapidly unconscious. You can see that the nurse has put sleeping there. Obviously he's not sleeping, he's unconscious by that point. It's all been signed, looks very neat, but obviously no clear action was taken. Evidence suggests that you can predict a cardiac arrest before it happens between about 8 to 24 hours. So there is a window to turn these patients around if they are for an escalation in their acute medical care. And with my old hat as an ICU registrar, it's far better that we turn around a patient who will only need 24 hours in ITU rather than admit someone who's got multi-organ failure who'll take weeks and months of recovery. So remember, this is the new school. We use a track and trigger philosophy, i.e. we are tracking the patient's vital signs, and then obviously we are triggering a response. So for example, getting a junior doctor review or the critical care outreach team. The new score should be fairly familiar to you by now and should be fairly straightforward. A couple of important points to make. Note that scale 1 should be your default for all patients except those who have known oxygen sensitivity, and the saturation scale is changed by a senior decision maker such as a registrar or consultant. You'll notice that patients who are on air get 0, oxygen get 2, but obviously again it's important to appreciate the amount of oxygen that they're on. Obviously a patient who's just on 2 litres of nasal specs compared to 15 litres of non-rebreather mask is obviously entirely different in clinical context. So systolic blood pressure, so you'll notice that it takes a 3 where you get a systolic blood pressure of greater than 220 millimeters of mercury. That simply reflects that hypertension is common, patients' blood pressures can vary significantly, and hypertensive encephalopathy is relatively rare. And finally, if a patient, for example, is hypertensive and have an acute stroke, if you drop the blood pressure too much, you'll actually worsen their infarction. Then you've got consciousness with alert, confused, voice, pain and unresponsiveness, and it's important that you know how to test those. So a patient who's obviously sat up and talking to you who is alert, but a patient who's sat up and confused, those who need a voice prompt to respond such as hello, can you hear me, can you open your eyes, those that require a trapezius squeeze to respond, and those who respond to none of the above will be unconscious. Temperature is relatively straightforward. You'll all be familiar with pyrexia associated with sepsis, but it's also important to appreciate cold sepsis. So these will be patients who are immunosuppressed, for example, on steroids, frail, elderly, and so on, and they won't mount a typical immune response. So obviously this just summarises some of the concepts that I've been talking about. Obviously what we want to avoid is the slippery slope of our patients. It's important obviously where we can to try and prevent acute illness, a clinical review, and making sure that we recognise any danger signs so that we can make interventions and decisions. Again, if our patient starts to deteriorate down the slope to death, as you'll see from the previous chart, it doesn't take long for a patient to proceed to cardiac arrest, but you do have a window in between the clinical review and rapid response before the patient deteriorates and dies. So we have an ABCDE approach, so airway, breathing, circulation, disability, and exposure. The importance of the ABCD approach is that you manage your life-threatening problems first. So airway obviously trumps, say, blood glucose or a rash. It's important that you evaluate the effects of treatment and intervention. So, for example, if you give a patient a fluid challenge, then you need to recheck their blood pressure to see if that intervention has been effective. Effective communication, such as with your registrar, your supervising clinician, critical care outreach team, surgeons, radiology, and so on, and that you escalate decisions early, i.e. whether your patient will be for critical care or whether they be palliated in the event of their deterioration. So as I said, when you approach your patient in the acute emergency department, you're going to perform your end of bed assessment. Obviously, it's important that you ensure your safety and obviously wear PPE if necessary. Ask your patient a simple question, get a lot of information, and it's a true mantra. Simply ask, by asking the patient how they feel, what brought them in, you'll be rapidly able to tell a number of things which I'm going to talk about now. So, for example, if you have a patient who you say, how are you feeling? And they say, I'm feeling fine, I feel much better than when I first came in, I've had this chest pain for a couple of days, etc., etc., then the fact that they can complete sentences, they're obviously coherent, means that they are reasonably stable. Although, of course, they will still have an acute problem, they are not unstable or need life-saving intervention. Whereas if you've got a patient who barely can get any sentences out, is using accessory muscles, is in the tripod position, and is barely able to speak, obviously they are potentially in a life-threatening situation. If, for example, they're not responsive, then obviously you're going to be worried about cerebral perfusion. Their blood pressure could be very low, or they've had an intracerebral event. Obviously, it's important at this stage of your training, if they are unconscious, then you must summon the medical emergency team via 2222 and contact the registrar. Take a moment to look at how they appear. Are they comfortable? Are they distressed? Are they content? Are they concerned? What's their colour and what's their posture? And obviously attach some monitoring. So these are the principles of the ABCDE assessment. Obviously, it's a team effort. So if you see a patient who's clearly unwell, you need to summon the emergency team and attach monitoring. Then, of course, in airway, you need to do a clinical assessment of the airway, and it's important to remember that airway assessment is all clinical. Do not rely on saturations to determine how patent someone's airway is. If their airway is clear, then apply high flow oxygen, but it might be that they need adjuncts such as oral and nasopharyngeal airways. When you assess their breathing, then you want to inspect, look at their work of breathing, take time to watch their respiratory rate and their respiratory mechanics, perform palpation, auscultation, and check their skin colour. You should be measuring the respiratory rate, oxygen saturations, take an arterial blood gas, and order a chest x-ray. For circulation, the picture on the left is a patient who is mottled due to severe sepsis. You want to again look at the appearance and colour, look for any mottling or rashes or any obvious bleeding. Check their heart rate, blood pressure, capillary refill time, temperature and urine output. Interventions that you should be performing include IV access, appropriate blood tests. Always consider taking a group and save or a cross match if you are concerned the patient is hemorrhaging, and a pregnancy test in women. Fluids and obviously an ECG. The disability assessment is basically asking your patient how well their brain's working. So this should be performed via the AVCPU, their pupils, and performing a basic crude neurological exam. Always check the blood glucose in someone who is poorly. For exposure, then you need to perform a secondary or top-to-toe examination. If, for example, you see any any wounds or ulcers, any ports of infection, then you should take swabs and cultures. Consider a PR, for example, for GI bleeding, and examine them musculoskeletally as well. So your 5 core measurements in an ABCDE assessment are respiratory rate, heart rate, capillary refill time, blood pressure, temperature, and urine output. Actually, that's 6. What's important is that ABCDE is a dynamic process. So I've talked about this sort of concept wheels in other talks such as shock. You need to be thinking about these 3 things: ABCDE, investigations, and management. Remember that ABCDE is a dynamic, continual process. Acutely unwell patients change all the time. Some will get better, some will get worse, and it's important that you recognize any change. So, for example, if you have a patient who's septic and they've got a low blood pressure, then assess them. Check their blood pressure, check it regularly. Has my intervention worked, such as giving a fluid challenge, and reassess. What investigations do I need? So hematology, biochemistry, microbiology, radiology, and an ECG. What interventions do I need? Does the patient need endoscopy after GI bleed? Has that endoscopy failed and they need interventional radiology? Have they had an NSTEMI and need a percutaneous coronary intervention, or do they need to go to theatre for a laparotomy? Think also about specialist input and review, so it could be cardiology, surgeons, critical care, and so on. Do they need antibiotics, fluids, oxygen? And also consider what escalation decisions you need to make, i.e. whether they're for theatre, ICU, or palliation. So you need to be thinking about this cycle of ABCDE investigations and management throughout your assessment of an acutely unwell patient. So some pearls and pitfalls. So these are some of my tips to help make your assessment of an acutely unwell patient a little bit easier. Remember that respiratory rate is the most sensitive marker of a deterioration. Pay attention to it. Make sure you count it properly. Assess respiratory mechanics. How easy or hard is it for your patient to breathe? Patients who are constantly struggling or are using up all their accessory muscles will quickly tire and deteriorate rapidly. Look at their muscle mass and nutritional state. Look inside their mouths, look at their teeth, look at their tongue, look at for muscle wasting and their strength. It's really important to pay attention to patients who are obese. Remember that they will have a reduced tidal volume, there'll be an increased work of breathing, they'll be prone to rapid desaturation, atelectasis, and venous thromboembolism. A critical point, and this is what I was saying earlier, only rely on saturations when people who are well. So remember, there's lots of things that will affect someone's SATs trace, including cool peripheries, poor perfusion, hypoxia, hypothermia, carbon monoxide, nail polish, dark skin pigmentation will all affect the readings of the SATs probe. As you become more senior and into your postgraduate training, it's important that you understand this concept of parallel planning. So as you assess, you should begin to construct your plans and begin to request time or decision critical investigations as you proceed. By the end of your ABCDE assessment, you should have identified the problem, which is not the same as a diagnosis, any interventions, and have a workup plan. So, for example, if a patient who is short of breath, you might identify the problem that they are hypoxic, but obviously you're going to need a chest x-ray, say, to confirm the pneumonia or lung cancer, and then obviously prepare what you're going to do from there. Don't forget to SBAR. So it's really important that when you're handing over these patients, you communicate clearly and you communicate with a good strategy. And so we recommend to you SBAR: situation, background, assessment, and recommendation. And I've put an example of here of a patient who's had left-sided chest pain for you to look at. One of the important skills in history taking in acute medicine is to understand a patient's trajectory of disease, and there are 4 ones that I've put on here. Some patients, for example, will have a sudden unexpected death. They'll be perfectly normal, well people, and have an unexpected catastrophic event, for example, being run over and killed. Some patients, however, will have a more predictable sharp decline, such as those who have metastatic malignancies. Some patients, however, will fit into the bottom one, and so organ failure, good example, is a patient who has COPD. They start off relatively high functioning, but as they continue to smoke and their lung function deteriorates, they have an exacerbation, say, of COPD in the winter time, get treated with oral antibiotics, steroids, nebulizers, get discharged, but their lung function continues to deteriorate. Then they have another exacerbation, so they never quite get back to what they were because their lung function continues to deteriorate. Then they'll have one big terminal exacerbation of their condition, which then results in their death. Frailty and dementia is a similar pattern. Again, this tends to be a fairly steady but rapid decline, and this will be patients who have prone to falls, those who have dementia and so on, and those who have multiple frailty syndromes. So frailty syndromes, it's important to always consider patients who are frail. Now, patients can be old and frail, but they can be young and frail as well. So, for example, there are overlapping domains of frailty. This will include cognitive defects. So, for example, those who have Alzheimer's or dementia, those who have functional impairments. So, for example, if they have osteoarthritis and can't, for example, use a knife and fork, they might have physical deficits such as be wheelchair bound, have a overlapping lack of social support, be malnourished, and have mood disorders. It's really important to pay attention to mood disorders such as acute depression in acute medical admissions. Some of our patients unfortunately present to ED after a suicide attempt or are suicidal, or they have chronic depression that's not been correctly identified and treated. So it's important to know about the clinical frailty scale. This is something that has really come into effect, particularly with COVID. So all patients who are over 50 should have a clinical frailty score performed, whether they are very fit at number 1 or terminally ill at number 9. There is also an app. If you download on iPhone the CFS app, you can perform the clinical frailty scale on your phone. So in a cardiac arrest, which will be under other tutorials, there are 4 key pillars of managing a cardiac arrest, but you'll notice that decision making comes all the way through, and this is one of the key attributes of a successful acute medicine student and successful acute physician. The principle of early recognition and calling for help to try and prevent a cardiac arrest, or deciding that they would not be for escalation and treatment, and therefore you would put a DNA CPR in situ. They tend to start CPR, then to recognize the rhythm, whether it's shockable or non-shockable, so you are deciding what interventions you're going to do, such as give adrenaline, shock the patient and so on, and what type of access you need, such as you may need to put in a central line or perform intraosseous access. Then if a patient should survive a cardiac arrest, you'll then have to make further decisions about whether they should be admitted to ITU, whether they should be palliated, and if they go to ITU, is there going to be a treatment and escalation plan for their stay on ITU. So there's also a lot of practical aspects to acute medicine. So for example, acute physicians are very good at blood gases, lumbar puncture, abdominal drains, advanced life support, chest drains and pleural taps, central venous catheters, airway management, ultrasound and echo. Acute physicians have intensive care competencies, and we're also trained in offering respiratory support. So hopefully in this 40-minute talk, I've given you an overview of the important principles of acute medicine, and hopefully you understand how the specialty works and what acute medicine means. Sometimes it does feel a little bit like working in ER, but many of the times it isn't. So again, hopefully you've got a bit of a flavour for what working in acute medicine is, and hopefully you'll enjoy the specialty, enjoy your training, and as always, I'm happy to take questions and comments. Please like and subscribe to YouTube, leave any comments or contact me via my university email. Thanks for listening.